First, again, hello, and thank you so much for joining me. I think I know most of you that are on today's call, but if I haven't had the pleasure of meeting you, my name is Bethany Bramwell. I'm one of the clinical consultant pharmacists with Guardian Pharmacy Missouri, and I live down in West Plains, Missouri. Today, we're actually going to be talking about beyond medication regimen reviews, quality measure focused consulting in long-term care. And again, thank you so much for joining me inside on the computer on a beautiful Friday afternoon when you could otherwise be out in the sunshine. Just a little bit of housekeeping first. I have no conflicts of interest to disclose, and if I happen to use drug names, it does not imply endorsement by myself or by my pharmacy. So today's session is really about you. It's about your quality measures and specifically the role that an engaged consultant pharmacist in collaboration with a determined multidisciplinary team can and should have in driving your quality measures in the direction that you want them to go. More than anything, I want to help you, and my team, of course, wants to help you, get those quality measures where you want them to be. And more than anything, for leadership teams that aren't used to being in the driver's seat with their quality measures, I'm hoping this will give you a little bit more of an idea on how you can actually impact them, and using the tools in your toolbox, including your consultant pharmacist, can help you get them where you want them to be. So normally in this presentation that I give live, I talk about, as we emerge from COVID, and are really able to refocus on such things, how many of you would say that your quality measures are one of your top priorities? Does anybody want to chime in and say where, like on a scale of 1 to 10, you guys are even putting your quality measures right now? I know it's kind of a tough time.
I mean, I will say for Willow, I mean, it's definitely something that we're putting more of a focus on and looking at. And from my experience, I mean, it's extremely important.
Mm-hmm. Right. And it's tough when you have so many other things on your plate, the survey teams coming back in and of course, all the staffing challenges that you guys deal with every day. It's really hard to keep things like your quality measures and your 5-star ratings as a top priority. But we find that the things that the leadership teams and their staff do every day are really what drives those measures. So again, I would also ask how many of you normally have your consultant pharmacist regularly attend your QAPI meeting. If you don't, I'm going to encourage you to invite them. And how many of you routinely provide your consultant pharmacist with a copy of your quality measure report every month? It's something that, this program was actually originally designed for pharmacists to teach them about the quality measures, how to work the quality measure report, and what sort of multidisciplinary initiatives that they could have the most impact on to help drive quality measures within homes. So this is just simply a summary of the program that essentially says if your consultant pharmacist isn't currently taking on roles within your quality assurance and performance improvement committee, they certainly should be. There's a place for them. They can be very effective in these roles. So let's talk about geriatrics by the numbers. You guys are well aware that the population that we care for is growing rapidly. Current projections estimate that our 65 and older population should double by the age of by 2050. And the 85 and older age group is expected to increase by 5-fold. So of course, with this group, we're going to anticipate the need for increased demand for collaboration among pharmacists, prescribers, and caregivers to really optimize medication therapy and patient safety. One of the trends that we're seeing is mid-level practitioners being full-time in the homes, and there's a lot of benefit to that. And the same is true with more of a real-time pharmacist as provider role, shifting away from the idea of your consultant pharmacist coming once a month to do retroactive reviews, and really practicing more in your home on a routine real-time basis. So of course, when I give this talk to pharmacists, I really discuss the actual quality measures in detail, but you guys know quality measures in detail. So I really want to approach this differently today and discuss these interventions in terms of what geriatricians call the geriatric syndromes. you'll see that there's a surprising overlap between the quality measures and the known geriatric syndromes. 4 of the top 5 geriatric syndromes equate to your quality measures. This isn't really surprising when we understand that these syndromes are considered reliable predictors of hospitalizations, increased healthcare use and cost, and even increased overall mortality. We are continually adding to this list of geriatric syndromes as we identify other clinical conditions in older adults that don't fit into specific disease categories. These are things that contribute to a need for a higher level of care. So the geriatric syndromes, just like the quality measures, overlap and are intertwined. I've grayed out pain here since it no longer appears on your CASPA report. But if you look at Mr. Kent, for example, you see that he triggered for pain, antipsychotics, falls, and a UTI, and needs increased help with his ADLs. So as we look at these quality measures of geriatric syndromes as being interconnected, if we're able to address Mr. Kent's pain, then possibly the need for an antipsychotic medication could be eliminated because he's no longer exhibiting, self-transferring and other behaviors that we perceive to be dangerous because he's more comfortable. Then, of course, off of the antipsychotic, he could be more alert and also in less pain. And then he could restart therapy maybe and restorative and other activities. And then we may notice as he improves his condition that we see an improvement in ADLs where he requires less assistance. And then, of course, we could see lower falls as we've removed potentially, high fall risk medication, plus restored some issues that we had seen with deconditioning when he wasn't able to get around on his own. So as pharmacists, we use this facility level report to really identify opportunities for overall improvement. And then we work with the care center to develop system-wide interventions. We use the resident level report to develop patient-centered interventions. Pharmacists can play a key role in improving all of the quality measures. System-wide, we do help to engage in multidisciplinary initiatives such as your performance improvement projects, your PIPs, but also educational programs, and then the development of policies, procedures, and protocols. We commonly sit on PIP teams. Almost every home has an ongoing PIP team for falls, but also for pain and antipsychotic use and weight loss, transitions in care. So if you haven't roped your consultant pharmacist onto a PIP team yet, I encourage you to do so. Of course, they're usually more than happy to sit on a team, but even more than that, they can often help to lead teams or help develop the structure or the foundation, or even help with the goals for the team. The second type of multidisciplinary initiative that consultant pharmacists are particularly well suited for is staff and provider education. We do commonly provide education to nursing and prescribers, and one of the challenges we encounter is kind of a lack of common language across these disciplines. So pharmacists tend to talk pharmacist speak, and physicians tend to talk their speak, and then nurses have their very own language. And so that's one of the things sometimes it's helpful in the education piece, is to help get us all speaking the same language across disciplines. And also what we have found, especially for education, is what works with one care center may not work for the next. Often this is due to prescribing practices or medical director preferences. So we have to be really careful making sure that we're flexible, and of course avoiding cookie cutter recommendations for processes and protocols. The pharmacist approach to education really has to be tailored for each discipline. We've found, for example, establishing rapport with the medical directors and prescribers is really key for any successful pharmacist-led intervention. Whereas successful nursing education really requires buy-in. It's important usually not to lead nursing education with regulations or quality data, but really focus on the aspects of patient-centered care. We've actually found through experience that to improve buy-in by nursing for initiatives such as changes to patient assessment or documentation, we're actually more successful when we bring in our clinical nurse educator to co-present with us. Like I said, because of sort of some of those language barriers, nurse-to-nurse education really tends to be most effective. And although the pharmacist really can play a key role in improving all of your quality measures, for this session, due to time mainly, we're going to focus on specifically the patient-centered interventions to improve 5 key areas. And I'm going to call these the big 5 today. Pain actually used to be in my top 5, and if we have time, I really still do want to address it. Just because pain doesn't occur on your Casper report anymore, I don't want to discount any of the quality measures. So we'll see if we can get to it as well. Of course, falls are always going to be number 1. They're an ongoing challenge for the entire multidisciplinary team, and I know your fall prevention programs never stop. What's interesting, though, is that there's really a lack of compelling evidence that any one intervention will reliably decrease your incidence of falls. And this is mainly due to multiple etiologies associated with falls. So your fall initiatives are really going to require consideration of each of these etiologies. So this is going to include physical, cognitive, and environmental factors. Of course, the pharmacists are going to focus on medications for the purpose of this session, but any initiative to reduce falls really should be comprehensive across all of the disciplines. Fall prevention through medication management has consistently been shown to reduce the risk of falls. However, reducing the number of medications a resident receives, as well as reducing or discontinuing specific high fall risk medications, is really often easier said than done. We do medication reviews all the time and ask for meds to come off, but patients and prescribers and physicians and nursing, we often encounter barriers or challenges or perceived effectiveness of medications. There's some real barriers to getting these medications discontinued sometimes. Actual changes to medication therapy really don't happen as often as they ought to. And this probably goes back to the buy-in piece. Our physicians especially, we have found that face-to-face provider academic detailing is usually more effective than a written pharmacist recommendation to get certain medications pulled off due to falls. So of course, you may be familiar with Beer's criteria or the start-stop criteria and others which really focus on discontinuing psychotropic medications such as antipsychotics or antidepressants or anti-anxiety medications to reduce falls. What you may not be aware of is that the use of medications that cause orthostatic hypotension may actually be a greater risk for serious falls than psychotropic medications. It's common for the multidisciplinary team and even the pharmacist to look at changing a resident's psychotropic medication first, like their antipsychotic or antidepressant, but the evidence actually supports looking at their blood pressure and heart medications first. In dementia patients specifically, there's 4 medication classes that are known to be associated with higher rates of falling. Anti-diabetic medications are one, so that's something we're going to be closely looking at is, are they over-medicated? Could they be controlled on a simpler diabetic regimen? Are we driving their blood sugars too low? Of course, we're going to look at pain medications, both over-medicating and under-medicating. If your patients are not comfortable, they are going to be on the move. And then heart and blood pressure medications, again, looking at the orthostatic hypotension, low heart rates, pre-syncope, those sorts of things are going to be important. And then, of course, the psychotropics. The cholinesterase inhibitors, such as donepezil or Aricept that we use to treat dementia, have also recently been added to the Beer's criteria because they've been shown to cause low heart rate. They can also cause dizziness with fainting. So as we reduce or discontinue these high-risk medications in dementia patients, we use this as an important intervention to reduce falling in your memory care units. We're really just trying to simplify their therapy as much as possible and make sure that the medications aren't contributing to their falls. So going back to the orthostatic hypotension piece, the American Society of Consultant Pharmacists and the National Council on Aging, in coordination with the CDC, they have a toolkit available to reduce fall risk called STEADI. It's STEADI, here the STEADI toolkit. This toolkit really emphasizes the importance of a multidisciplinary approach to falls, and it helps to guide clinicians through the medications and medical conditions that contribute to falls. The STEADI toolkit actually includes a medication assessment that focuses on areas that your consultant pharmacists commonly target, including things like polypharmacy, recent medication changes, and excessive doses. In many cases, there's actually safer alternative medications for patients with recurrent falls. So even if the patient or the prescriber is reluctant to discontinue one medication, sometimes we have the opportunity to offer an alternative that's lower risk to them. AHRQ also has a falls management program, and it again emphasizes the importance of an interdisciplinary or multidisciplinary team to address falls. And then similar to the STEADI toolkit, AHRQ's program really requires consideration of these multiple etiologies for falls. So we're looking at physical, cognitive, environmental factors. We want to include nursing, but also therapy, activities, restorative, your prescribers and your pharmacists. Encourage all of them to be on your fall program to be sure that each of these intrinsic fall risk factors are addressed. A couple of weeks ago, we had Patient Safety Awareness Week. And of course, that's a great time to go back and look at resident safety awareness initiatives. And I happened to notice an article that came out about the Community Medical Center in Missoula, Montana. They actually staged a room occupied by Miss Mayhem, and they had a prize for the person that could identify all the safety issues in a room. So it was a lot of fun. They put this, fake resident in this room, and they had all of these safety issues in the room, and then had staff go by and identify all of these issues. And so that helps with like your extrinsic fall risk factors. I thought that was a lot of fun, a Miss Mayhem room. So of course, central to the fall reduction initiatives is root cause analysis. The fall team will start with the main question, why did Bob fall? And of course, the answer, may seem simple. He tried to get up, or he tried to get himself to the bathroom. And so if the team stops at the first question, they often fail to find root cause. And then of course, they may try to keep Bob seated with the use of alarms or call light reminders or restraints or medications. And so if we can get past that first question and let's say, well, why did Bob try to get up? Well, why can't he walk anymore? And then why is he weaker, or why is he stiff? Does he need a medication change? Why is he losing weight? And why is he not eating? And so as we start to ask, I think they say normal root cause analysis usually takes anywhere from 5 to 8 whys until you really get back to the root of what's going on with your patient. One of the things that we have found, especially for root cause analysis when we're looking at medications, is that often patients are willing to try to stop a medication if their doctor says it's possible. And so that's really something that if we're not having luck getting a medication changed because the patient or the family wants to keep it on, we really need that buy-in from the physician to help us with that. So in summary, there are 4 evidence-based areas to focus on with your multidisciplinary team. The first is to prevent syncope and reviewing your processes or procedures for measuring orthostatic blood pressures. Orthostatic blood pressures in long-term care are often inaccurate due to the measurements being taken at incorrect time intervals. This is something that our pharmacists routinely notice when we're looking at post-fall evaluations or when orthos are ordered. So consider evaluating your competencies and assessing orthostatic blood pressures. The CDC STEADI toolkit does have a fill-in-the-blank chart format for each position and the timing between that, so you can use that tool to help train your staff. Second, it's really important to evaluate staff's ability to recognize pain, discomfort, the resident's desire to move, and of course, prevent boredom. Obviously, that takes a complete multidisciplinary initiative to hit all of those targets. And so you have to make sure you get activities, therapy, and restorative involved to promote appropriate exercise and activities. And fourth, and then this is probably one of the most challenging and sometimes a touchy subject, is to really look at the staffing issues and how that can be contributing to your fall rates. As you look at your fall numbers, pay attention to, when those are occurring in relation to staffing. So on to number 2 on my big 5 list is antipsychotic use. It's really important to know that a pharmacist working in a silo will be unable to move the needle on your antipsychotic numbers. So if you're relying on your pharmacist doing routine gradual dose reduction reviews to drive your antipsychotic numbers down in your home, I can promise you that it will not work. What does work is when we have buy-in from facility leadership, nursing, and the providers. It's really only then that we see successful antipsychotic reduction initiatives, and they can be really powerful. Even just a pharmacist and a physician working strategically together to reduce antipsychotic use can result in double-digit drops in your antipsychotic use percentages. However, if you don't have that buy-in from nursing to support those initiatives, those numbers can often climb right back up as nursing reports, behaviors, and especially if they don't feel empowered with tools other than medication to help to manage them. The American Psychiatric Association does have deprescribing guidelines for antipsychotics used in dementia. Of course, the goal of these guidelines is to help improve the care of patients with dementia who are having agitation or psychosis. Specifically, they focus on the judicious use of antipsychotics in dementia, and they don't really talk about the evidence for or focus on other pharmacological interventions. So despite commonly held notions that antipsychotics are effective for behavioral and psychological symptoms of dementia, in clinical trials, the benefits of antipsychotic medications are small at best. There is, however, consistent evidence that antipsychotics are associated with clinically significant adverse effects, including mortality. So a couple of things about tapering as we bring patients off of antipsychotics. Patients who've received antipsychotics longer tend to need a longer, slower taper. So what we have to be very careful to do is have a plan in place for recurring symptoms during the taper process. Often antipsychotics are restarted or the doses are increased right back up in the first week after a reduction or a DC. And often this is nursing driven and it has to do with nursing requests or reports of recurring symptoms. And so if we have that plan in place and the nursing team feels much more empowered or even has control over the tapering process itself, getting that buy-in seems to be really important to avoid having the antipsychotic doses come right back up. Quantitative behavior monitoring before and after a reduction is really helpful to illustrate changes or lack of change in the resident's behavior. So for example, 2 episodes of combativeness with cares in the 30 days prior to a reduction, and then if you have 2 episodes in the 30 days after, it really illustrates a lack of efficacy in your antipsychotic, not as opposed to the need for an antipsychotic. So when we present the evidence of behaviors quantitatively, we often can see the lack of efficacy of our antipsychotics much more clear. So again, this example of you've got a resident who has 2 episodes of combativeness with cares and 1 episode of hitting in the month prior to a drug reduction, and then we reduce it slowly over a month, and then in the following month you see the same number of episodes of behaviors. We're really looking at a lack of efficacy of our antipsychotic for managing those behaviors. So when you can look at those month snapshots at a time, it's super helpful. I know a lot of the homes have gone away from monthly behavior charting and have gone toward more of a narrative behavior charting. And I'm not opposed to narrative behavior charting, but when you can't view it quantitatively, and when you read the timeline narrative and it says, okay, on Thursday, Mrs. Smith's risperidone was reduced, and on Saturday and Sunday, she had these behaviors, all of a sudden you start to see a cause and effect relationship that may not actually exist. Whereas if you can look at a prior 30-day snapshot of behaviors before and after, then it becomes much more clear. So the HALT project was an initiative that focused on deprescribing plus staff education. Education was a train the trainer model in this study with a 3-day workshop for nurse champions who then went on to train the residents' care staff. At the beginning of this study, 61.2% of residents were receiving risperidone for behavioral symptoms of dementia. 18% of them were on quetiapine and 13% on olanzapine. The results were really remarkable. More than 80% of residents were off their antipsychotics by the end of 12 months, and they saw no change in their NPI scores. The NPI is a measurement of behaviors and hallucinations and delusions. So this was really kind of a hallmark trial to illustrate how well we can do of getting patients off their antipsychotics. And really, when you look at the big numbers, you're not seeing a true change in behaviors. We learned a couple of important things from the HALT project. One is that nursing champions and nursing buy-in are essential to make sure that discontinued antipsychotics don't get replaced with other drugs. And two, again, the quantitative monitoring and documentation are key. These residents in the study were monitored for symptom frequency and severity for 2 months prior to their medications being reduced. And then having these numbers available really helped to monitor for any true reemergence or change in behaviors. Couple of challenges that we encountered by the HALT project are really similar to what we see in the communities. Having a lack of leadership commitment, including a lack of dementia training, lack of processes or facility training, really lack of nursing and prescriber buy-in, and of course the family and the resident fears as well. So we have several examples of success stories and then relapses, even here in Southern Missouri. I've got a couple of case studies. One in particular is we had a medical director and primary prescriber that we got buy-in for and worked with the consultant pharmacist. This was in about a 100-bed skilled building in Southern Missouri. What we did is a systematic gradual dose reduction request from the pharmacist, and we targeted patients, again, in collaboration with the medical director and their primary prescriber. We targeted residents that were only exhibiting behaviors. So we didn't focus on reducing the antipsychotics for residents who were having hallucinations or distressing delusions. So we were just focusing on those physical and verbal behaviors. And we took our time and pulled the patients off over about a 3-month period. And this resulted in reducing the antipsychotics from over 25% usage in the building down to about 11% in the building. But then what happened in the subsequent year to 18 months is the medical director actually retired and was replaced with physicians who we didn't have the same relationship with, didn't have the buy-in. And it took about 2 years, but now the antipsychotic use is back well above 25% in that home. And so this is just an example of how, it's never one person on the team that can make this happen. You've got to have that multidisciplinary approach to have a successful program. So in summary, evidence-based interventions to reduce antipsychotic use include provider detailing. The pharmacist or even the leadership in the home having those conversations with the providers about, hey, this is a priority to us, and here's why it's important, and here's the evidence that supports it. A process called prospective reviews, which is sort of like an in-house prior authorization program. You'll have a behavior management team, usually includes your director of nursing, your consultant pharmacist, and maybe 1 or 2 nurse champions in your home. And before an antipsychotic gets reduced or increased back, that they come to the huddle and they decide, hey, what are we going to ask for? How are we going to manage this change? With those prospective reviews, we do see significantly fewer new antipsychotic starts. We also see much better improved documentation. Again, also the quantitative behavior monitoring is key for deprescribing initiatives. And also letting nurses choose the interventions, again, having that behavior management team and let nursing choose the rate and the duration of a taper in a resident has been really powerful. So number 3 on my big 5 list is weight loss. And if you can only take one thing away from this topic today, is that adding an appetite stimulant should never be your first or even second intervention for weight loss. Just like with falls, it's very important with weight loss to look at root cause to be done. And unfortunately, too often we do see where, weight loss gets reported to the physician and the physician starts an appetite stimulant without ever going through that complete process of root cause analysis to figure out why the patient may be losing weight. So there are disease-related factors that contribute to weight loss, including constipation, pressure ulcers, and especially daily pain. But the leading cause of involuntary weight loss is actually depression, especially in long-term care residents. Of course, cancer and cardiac disorders and benign GI diseases. Medications that can cause nausea and vomiting and dysphagia and dysgeusia and anorexia have been implicated, but not quite to the extent that the actual disease-related factors are. We also know that polypharmacy can cause unintended weight loss, as can psychotropic medication reduction, usually by unmasking problems such as anxiety. So while it is important for the pharmacist to review drugs that could be contributing to weight loss, actual drug-induced weight loss, we think only accounts for about 2% of cases, whereas psychiatric conditions, especially undertreated depression, can contribute up to about 42% of cases. So of course, there's a whole slew of side effects, meds that cause side effects known to contribute to weight loss, especially these medications that cause anorexia and dry mouth, changes in taste, or swallowing issues. What we do look at is with patients with significant weight loss, as a pharmacist, we want to look at time to benefit of many of these agents. So that's important for us if we're looking at the bisphosphonates like Fosamax for osteoporosis that can contribute to esophageal irritation. Does this patient really need this medication at this stage in their life? So really that's what we're looking at is the time to benefit. And the donepezil or Aricept is a good example for that. It is known to cause, nausea, vomiting, diarrhea, but it's also intended to improve the patient's cognition. So we don't always want to recommend the drug we pulled away if we think it's going to reduce, their cognitive function and in turn their physical function. So mirtazapine is commonly added as an appetite stimulant. That's the generic Remeron. But many prescribers actually forget that mirtazapine is an antidepressant. It's actually a really effective antidepressant. And what will happen is we get mirtazapine added, but then the other current, SSRI or SNRI, like your Lexapros and your Celexa, doesn't in turn get reduced or DC'd. So you're missing some of the benefit and can possibly be over-medicating patients when we add Remeron. So a pharmacist-led intervention can really help to illustrate a couple of things, that time to benefit, and then the polypharmacy. And we can really help to reduce drug burden for these patients. So looking at evidence-based recommendations for addressing weight loss, we first want to identify and treat our underlying cause. Certainly look at using screening tools such as the mini mental status exam, the MMSE, and your geriatric depression scale. We don't like to rely on the PHQ-9 mood interview scale from the MDS as a reliable indicator of depressive symptoms. It's not really validated in older older patients with dementia, and it's never meant to be a diagnostic tool. So unfortunately, the PHQ-9 has and we'll talk about that when we talk about depression. But I really encourage you to use either the geriatric depression scale or the Cornell scale for depression in dementia. As more validated tools for assessing depression in your geriatric patients. So the other key evidence-based recommendation is to initiate nutritional support early. Don't wait until the weight loss is significant. Certainly add your nutritional support early on. And of course, again, don't consider drugs as first-line treatment. Data is actually really lacking on medications, including like the dronabinol and Megace or Megestrol that you see commonly used. They're both commonly prescribed, but their efficacy is not clear, and there are real adverse effects to those. Mirtazapine or Remeron in comparison has been found to increase appetite and weight in adults compared with placebo and other antidepressants. The word of caution, though, about using mirtazapine and Remeron is understanding how it works to increase weight. And what it does is it increases hunger, or the perception of hunger. And so if you have a patient who is not cognitively intact enough to let you know that they're hungry, you know, if you've got a patient who is nonverbal or who has advanced dementia, all you're going to do with mirtazapine is make an uncomfortable, hungry person rather than actually contributing to weight gain. And so as long as you've got a patient that can say, hey, I'm hungry, then adding the mirtazapine is a reasonable option. Of course, the contribution of your dietitians, your speech therapists, and social services personnel cannot be overstated. The efforts of the team can really improve many aspects of increasing food intake. Of course, social services might want to include your activities director, restorative aides, life enrichment, as well as talking to Geri Psych, especially if we think there's an underlying psychological or mental health component to a resident's weight loss. So on to number 4 on my big 5 is actually not a quality measure, it's an outcome measure, but I know it's certainly tied to reimbursement in ways that your other quality measures are not. And I want to talk about rehospitalizations. This is also an outcome that your pharmacist with your multidisciplinary team can really help drive, especially because we know that mismanagement of medications and adverse drug events are a leading cause of preventable rehospitalizations. The discharge orders that you receive from the hospital, you know, and I know, are often a mess. So a pharmacist's medication review at the time of admission can really help to reduce medication errors and reduce the use of high risk or inappropriate medications. And this goes back to what I was referring to about a paradigm shift in the way that I anticipate pharmacists in the coming years are going to be working in your homes. You know, of course, we just got the mandate not too long ago about doing these admission medication regimen reviews, and it really highlights the importance of your pharmacist. And even if your pharmacist isn't actually doing these reviews for you, they can help set up the policies and procedures and maybe help with the training for your nursing team that is doing these reviews. So one of your initiatives to reduce rehospitalization rates that you should prioritize this fall is to increase the rates of staff and residents receiving their flu shots. We know in studies have demonstrated that high dose flu vaccine compared to standard dose has been shown to reduce all-cause hospitalization. So it's important if you've got a resident over the age of 65 and high dose vaccine is available to you to go ahead and use it. Of course, increasing your staff vaccination rates, which unfortunately tend to be lower in long-term care than they do in other healthcare settings, and especially are low, sometimes well under 50% in rural areas of Missouri. So I do encourage you to do whatever you can to increase your staff vaccination rates in your home. We also know that polypharmacy and inappropriate medications called PIMS are consistently associated with all-cause hospitalization. What may be interesting to you is the specific drugs on the list that are known to be associated with rehospitalization, higher rehospitalization rates. One is warfarin, just because of the bleeding risk. Warfarin is high on your rehospitalization list. NSAIDs like ibuprofen, meloxicam, diclofenac, naproxen, those that can contribute to GI upset and GI bleeds. NSAIDs are high on the list of meds contributing to rehospitalizations. But so are medications like pantoprazole and omeprazole, which are what we normally think about as your GI protectant meds. And we see patients come out with these medications altogether, but they are actually associated with higher rehospitalization rates. So screening for these high-risk medications and discontinuing NSAIDs, for example, really should be a priority for most newly admitted residents. So for example, with the pantoprazole and omeprazole, we want to look on why the patient's on it, why were they added on it, and how does it increase the risk for this patient. And in most cases, it is infectious related. The proton pump inhibitors have been associated with higher rates of respiratory and gut infections. And so if there's not a clear indication for the patients to be on the medications, they need to be pulled off. So obviously, close monitoring of PTINRs to follow your warfarin therapy in the days to week after admission, especially you get patients who come into you who either their anticoagulant was stopped and now it's getting restarted, that they're admitted to you. Sometimes we have patients come in with warfarin but no standing orders, and we still have homes that don't have automatic standing orders for PTINRs on all patients on warfarin. Just like we have some homes that still don't have automatic standing orders for patients who are on insulin to automatically check their blood sugars. So sometimes the patient will come with their insulin and don't come with a blood sugar order, and then your patients will wind up hypoglycemic. There is a tool called the Medication Appropriateness Index, the MAI, which pharmacists can use to help assess a resident's risk of rehospitalization and risk of adverse drug reactions. It is a useful tool for helping detect changes in prescribing patterns over time. And it's one of the few tools out there that really has been validated to assess the risk of the cocktail of medications that a resident is on and associate that with their risk of rehospitalization. So in summary, our evidence-based interventions for reducing our rehospitalization rates include admission medication regimen reviews, which needs to include a thorough medication reconciliation. There are some horror stories out there about MedRec and MedRec processes. Some of the things that we see are patients who were on high dose opioids at home, and they come into the hospital and don't report that information. And so then they come to the facility 3 days later and they wind up in opioid withdrawals, which if you're not looking for that and a MedRec didn't happen all the way back to when they were at home, you might not see that. The same is true with the psychotropic medications. Invariably, we'll see a patient who gets discharged out to Geri Psych facility, and we don't get access to the the facility's Mars until the patient comes back. And so we think they should be stable on what they're on. And what we didn't know is that the Geri Psych facility was giving them 10 milligrams of HALT a day for 5 days, and now they don't have that order. And so a complete MedRec that goes through the home medications and the hospital or other healthcare organizations Mars, those are very important. Of course, having standardized treatment and monitoring protocols on admission. If you don't have a standard treatment or monitoring protocol order set, I would encourage you to work on developing that. Your pharmacist can help with that and in collaboration with your medical director and your nursing teams. Things like PTINRs on admission, of course, monthly, and then on day 4 of interacting antibiotics. We also recommend an antibiotic day 3 timeout to reassess antibiotic use on every patient that comes in. There should be a huddle that happens about that time to know, hey, why is this patient on the antibiotic? Do they still need it? Did we get the culture and sensitivity from the hospital? Probably not, but we need to call and get that. Blood sugar checks, again, for all insulin dependent diabetics on admission, standing order blood sugar alert parameters. So even if you have the blood sugar checks ordered, do you have alert parameters automatic for when to notify your prescribers for things that fall outside? The same is true for weights and weight alert parameters for your heart failure patients. Invariably, we'll see the hospital will have patients on 120 milligrams of Lasix at the hospital, but then they discharge them on 20 milligrams, PO. And if we're not aware of that because we didn't go through the Mars at the hospital, and then we're not doing daily weights on the patient, your patient is going to be back in the hospital in the next 5 to 7 days for a heart failure exacerbation. And so really having those, having each of these interventions in place can really help prevent your patients from going right back out. The same is true for vital sign alert parameters, making sure that you've got your highs and lows and changes from baseline. Your PIPs, your performance improvement projects, can actually focus on competency evaluations for each of these disease states. So that's an idea for future PIP projects, is to really look at your standardized, admission protocols. Last but not least, let's talk about depression. So COVID and the resulting isolation has really resulted in a significant uptick in the number of residents triggering for depressive symptoms. I'm sure many of you have seen this in your home in the past year. Depression was already at a staggering 48 to 50% of residents in nursing homes. And of course, with COVID isolation, it has really become an epidemic. So it's really important for clinicians to understand that depression in nursing home residents is actually very different than in community dwelling seniors. And many of our residents actually don't meet the diagnosis criteria for major depressive disorder, despite their symptoms impacting their quality of life. It's really not possible to treat depression in nursing home residents with medication alone. It really takes an integrated approach to alleviate their social isolation, address any environmental stressors, and in many cases, medications are not often needed at all. I'm going to go back to revisiting the PHQ-9 mood assessment score. Again, it is meant to be a screening tool to help identify residents who need further evaluation for depression. It was never meant to be diagnostic. And so unfortunately, too often we will see a report to the physician or referral to provider that says patient's PHQ-9 is 23, and that's the end of what it says, no further assessment. And then the prescriber's response is start Celexa 10 milligrams when it turns out they're on 3 interacting drugs. What we would really like to see is a full workup on that patient for depression, get a true diagnosis. And of course, that involves usually face-to-face with a clinician. I encourage you to supplement your PHQ-9 mood interview scores that are positive, that trigger above 7. Supplement them again with a GDS, that's the Geriatric Depression Scale, or supplement them with a Cornell scale for depression and dementia, which is validated for your dementia patients. Antidepressants can be effective in older adults, especially when they're paired with other non-pharmacological therapies. Older adults, though, are at much higher risk for adverse effects associated with antidepressant medications, and your pharmacist can often help you select the right antidepressant based on patient-specific factors. Again, many of the antidepressants' side effect profiles are not compatible with your patients. So if you have a patient losing weight, we certainly don't want to use Wellbutrin because that's going to make that worse. We want to use Remeron in that patient. If you've got a patient who has depression plus sleep disturbances plus anxiety, we don't want to use often Celexa or Lexapro in those patients. We want to use, Remeron or Trazodone in those patients. So really having the pharmacist help get involved in recommendations to look at those patient-specific factors is very important. Barriers to geri-psych services really continue to be a challenge in long-term care, especially in rural Missouri. Many homes are left without access to the non-pharmacological intervention with the best evidence, which is actually cognitive behavioral therapy, or CBT. So there are a couple of things that you can do if you don't have access to geri-psych services in your home. One is actually bright light therapy. There's pretty good evidence to show that 5 days a week of the 10,000 lux, which is the therapeutic dose of bright light therapy, doing that 30 minutes a day. In one study, they showed 50% of participants no longer scored in the depressed range on the geriatric depression scale. And it has also been shown to improve cognitive symptoms. And bright lights are not very expensive. You can buy them on Amazon for $30. And so if you aren't currently using bright light therapy in your home and you haven't tried that, I'm sure you can probably think of a resident or two that might benefit from that. Dog-assisted therapy has also been proven to be effective in reducing symptoms of depression in our institutionalized elderly patients. The increase in verbal interactions with the handlers throughout the study suggests that the dog really acts more as a facilitator of social interaction. So dog-assisted therapy really shows promising results, especially in the perception of illness timeline and treatment control. The thing that really has to happen with this is it has to be routine because, and I think we'll talk about this in the next slide, it's really more about the anticipation of an event and then the recollection of the event than the event in itself. So any one-off, pet therapies or any therapy, whether it's, music or any of the activities therapy, a one-off is likely not going to get the results you want. It really needs to be a routine scheduled activity that the patients know when it's going to happen so they can begin to look forward to it. And in talking about this, the psychosocial interventions that enhance socialization really need to focus on residents' choice and their pre-admission preferences. There was a study that Dr. Rosen did that talked about the positive therapeutic impact, and where he found an almost 50% change in residents with major or minor depression. And really what he focused on was the components of pleasure, anticipation, the experience, and the reminiscence. The residents really want to look forward to the activity and say that they actually enjoy that part more than the activity itself. And I know that you guys have great activities departments. You've got great restorative teams, super creative people out there. Certainly use them. Your residents that are suffering from depression, any resident who's on an antidepressant should definitely be a person that you've got activities or restorative involved in, coming up with activities specifically targeted for their depression. A couple of examples that Dr. Rosen mentioned in the homes that he has done is he gave an example of, this guy who was an avid golfer before he suffered a stroke. And so they gave him with a putting iron and a green to put down the hall. And so once a week, they set it up for him down the hallway so that he could work on his putting skills. And so obviously not only did he enjoy this and got to look forward to it every week, apparently several female residents would watch and place bets on whether or not he could make his putts. So he was not only enjoying an activity himself, but he was also providing entertainment for his co-residents. And I know things like that, COVID has certainly made these sorts of, activities challenging, but especially now that families are coming back in the homes. Another example that Dr. Rosen mentioned was he had a gentleman who was a long-term Pittsburgh Steelers football fan, and he really got depressed after admission, and he stopped watching football. It's bad when you stop watching football. So the care center actually arranged to reserve a television lounge where his kids and grandkids and other residents could come and watch the Steelers play every Sunday. So it was something that he was able to look forward to with, a group of people coming with him to watch football. So I just, in the few minutes I have left, I do want to talk about pain for just a second. Pain was formerly on my top 5. So even though it does not appear on your CASPR, your residents have not stopped reporting pain. I don't want you to forget that addressing pain can really help move the needle on your other quality measures, specifically anti-anxiety use, our anxiolytic use. This is something that we have seen go up during COVID, and many homes are no longer triggering on their antipsychotics, but now they're triggering on their anti-anxiety medications. Make sure that when you're trying to move the needle on that, that you're looking at pain. Pain can also certainly affect your weight loss numbers, your pressure ulcer numbers. If a patient doesn't want to move because they hurt, then you're going to wind up with more pressure ulcers. And of course, there's 3 or 4 other of your quality measures that pain can affect. So I'm disappointed that CMS chose to take pain off of your CASPR report. I understand why they did it, because they did find that we were chasing pain numbers with narcotics, which was driving up your narcotic numbers, and they felt that we were somehow contributing to the opioid crisis. So I just don't want us to forget it just because it's not triggering on the report for us each month. We do still know that patients are under-recognized and under-treated for pain in the long-term care setting. We know that usually more than half of older adults in long-term care are experiencing some form of pain. So let's certainly not forget about it. When we talk about pain, QAPI initiatives, we really want to talk about educating our staff to recognize pain, make sure that you're including pain evaluations and part of your routine nursing competency assessments. And then, of course, to improve pain, we really have to talk about consistent documentation. So even though you're noting pain scores, when you're giving the hydrocodone, you've got to note the pain scores on follow-up, because then without that, there's no real way to assess the efficacy of your pain medication. And finally, just like all of our other initiatives, pain is definitely a multidisciplinary project. It is going to include literally every person that comes to your community to help address our residents with pain. So I think that this quote from Frank Grosso, who was the president of the American Society for Consultant Pharmacists, basically said in this new patient-centered care reimbursement models, providers are going to be rewarded for positive outcomes. And so a pharmacist's role in reducing your patient's length of stay while simultaneously reducing rehospitalization is a better measure of positive performance than the lowest cost of medication per patient day. So I think that's really profound and kind of speaks to where the pharmacists are going, that we are really there to help drive your numbers where you want to be, to reduce your rehospitalization rates, and really look in the near future for your pharmacist to be much more of a real-time provider in your home, rather than just a retrospective reviewer of a snapshot of the prior month's activities. I will send out a copy of the slide deck to everyone who attended today. And then also probably midweek next week, this presentation, a live recording of it will be available on our YouTube channel. I also want to remind you that if you're a licensed nursing home administrator, we did get authorization for 1 hour of continuing education. So following the presentation, within the hour, I will get sent out to you the program evaluation form, which if you want credit for today's session, you'll need to complete that and then email that in to Cindy at Manhall. All that information will be available to you. So now I'm going to open up the floor to questions. Does anybody have any questions or case studies that they want to share or talk about? I think everyone went outside to enjoy the afternoon. Like I lost you all.
You didn't lose me. I thought it was great, Bethany. Thank you very much.
All right. Well, thank you. Andrea, did you have a question? All right. Well, if that's it, I will let you all go. And of course, I will, again, forward the program evaluation to you for you to send in for credit. My email address is there. If you have any questions or want to visit about quality measure focused consulting, either myself or Hillary are happy to visit with you about it. Okay. Everybody have a wonderful weekend and happy Easter.